Good morning, everyone. Our numbers are climbing here. I'll just give it another few seconds to let everyone get admitted to this symposium. So good morning, everyone. I'm Cynthia Whitehead, Director of the Wilson Center and scientist. It is my enormous pleasure to welcome all of you today to this Hodges Symposium 2022. And you're in for a real treat, I think. We have a fabulous and exciting program for everyone today. I welcome colleagues from near and far, new colleagues who've been part of our community for a very long time. And this morning we'll be engaging in collegial and critical reflections on, as a community. We will recognize our history, acknowledge present realities, and be thinking creatively about the future. This symposium is the Brian Hodges Day Symposium in honor of Brian Hodges, the second director of the Wilson Center. And true to his legacy and his vision, we will really be thinking together in critical ways about what it is important to preserve about in our field, what current structures and processes might require change, and how we think about moving into the future. I want to thank Mathieu Albert, the chair of this committee, and everyone on the committee for assembling such an exciting set of speakers and program. And I know that you'll all be inspired and at times find things that will push your thinking and help you consider new ways of thinking about our field and our community. This is entitled Enactments of Power, and we will have a series of wonderful speakers. And so thank you again to Mathieu and the committee for arranging this time. And Mathieu, over to you so we can get started with all of the wonderful talks that we have today.
Thank you, Cynthia. Hello, everyone. Yeah, each year, I'm impressed and very happy to, I don't know, it's like we're meeting the extended Wilson Center family at Hodges Symposium, and this is happening now today. Hopefully, it's going to be last time that it's going to be virtual, and next time we will meet in person. Let's hope for the best. Yeah, so we have a fabulous list of a speaker today, strong scholar, some juniors, and all other presenter more senior, but all very strong. Before I introduce the speaker, let me acknowledge the land on which we are. So for 1,000 years, this land has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. And today, this meeting place is still the home of many indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. So let me now say a few words. I will take a few minutes here to introduce each of the speakers. So first speaker is Tanya Jenkins. Yeah, Tanya is a friend for a long time. I've been known Tanya since she was doing her PhD. At Brown University, and now Tanya is assistant professor of sociology at the University of North Carolina at Chapel Hill. Her scholarship focuses on the social, professional, and institutional factor that shape physicians' and patients' lived experience. Tanya published a really great book 2 years ago. She came to visit us, I think 2 years ago, to talk about her book. The title is Doctor's Order: The Making of Status Hierarchies in the Elite Profession. So this is for Tanya, first speaker. Then we will have Laura Olsen. Laura is an assistant professor in the Department of Sociology at Temple University. Laura's research focuses on the incorporation of the humanities and social sciences into medical education. So I'm really personally looking forward to Laura's talk, since it does intersect with the kind of work I do. The third speaker would be Kelly Underman. Kelly is an assistant professor in the Department of Sociology at the Drexel University. She's also a member of the Center for Science, Technology, and Society at Drexel University. Kelly also published a book 2 years ago, and she came to us to talk about her book 2 years ago, I believe. So her book title is Feeling Medicine: How the Pelvic Exam Shapes Medical Training. Then we have Paula. Everybody know Paula Rowland. So Paula is a scientist at the Wilson Center. She is also a member of the Institute for Education Research at UHM. And Paula's research is on the intersection between professions and professional training in the clinical workplace. Then we will have Tim. Yeah, sorry, Tim, for the pronunciation here. Tim Mickleborough, yeah. So Tim is a pharmacist, but I believe he stopped being a pharmacist and he transited into becoming a researcher in health profession education research. And he is currently a postdoc fellow at the Wilson Center, and his research examined professional identities and the boundary process in professional life. So those are the 5 presenters, and we also have a discussant, which is Tina. Everybody know Tina. Tina is a scientist at the Wilson Center and also at the Institute for Education Research at UHM. And Tina is not an associate professor. She is now, for the last 2 weeks, she is a full professor. Congratulations, Tina. This is great news. It's so much well-deserved on your part. This is really, I'm very happy. Everybody is very happy for your promotion. So Tina now is full prof, yeah. And Tina has been studying for years and years. This is really your core area of research. This is the sociopolitics of education, yeah. So in Tina's work, she combined ethnographic and discourse analysis. And with those tools, she tracks the effect of several interconnected discourse, such as discourse on compassion, integration, globalization, and collaboration. So those are our 5 speakers and our discussant, Tina. So the way it will unfold this morning, so each presenter will have approximately 15 minutes, maybe a bit more, maybe a bit less, but approximately 15 minutes to present their work. So after the 5 presentation, we will take a 5-minute break because that will add up to about close to an hour and a half. So we'll take a break after the 5 presentation. And after that, Tina will share her thought, reflections on today's talk. And we will open up to the audience for question, answer, discussion for about 20, 30 minutes. So that's a program for today. Just a technical note here. So today it's, yeah. So everybody, yeah, how can I, okay. So in the question and answer, yeah, period at the end, okay, yeah, when we have the conversation with the audience. So at that time, please raise your virtual hand with the yellow icon somewhere at the bottom, and I will see that, and I will call you to ask your question orally. So this is how it's going to work today. And beside that, please keep your microphone off. during the presentation today. Okay. So yeah, so this is it. Look, so first presentation, Tanya, c'est à ton tour. Okay. Bonne présentation.
Nice to meet you, and thank you all so much for being here this morning. It's just my pleasure to be able to give this talk. Let me share my screen, and please at any time, if you can't hear or see me, let me know. I hope you all can see my slides okay. These are my disclosures. And as Metzer mentioned, I published a book 2 years ago called Doctor's Orders. And so today I'll be bringing you findings from that book. The book explores how status hierarchies form between physicians with different training backgrounds. And so this morning, I'll be focusing on a very specific facet of power, namely the process by which status, or as we sociologists refer to as social prestige, gets negotiated within the medical profession. So it's been really since the beginning of modern residency training in the United States in the 1950s that the country has relied on international and osteopathic medical graduates, what I collectively refer to as non-USMDs, to staff anywhere between 20 and 50% of residency positions nationwide, because there's a shortage of American graduated MDs, or USMDs as I call them. Just as a reminder, south of the border, doctors of osteopathic medicine, or DOs, are allowed to practice medicine much like MDs in the US. USMDs and non-USMDs are not distributed evenly, however. USMDs disproportionately fill more prestigious and competitive residency positions, while non-USMDs typically fill positions in lower status, less desirable locations. In some cases, it's actually resulted in heavily segregated training environments, with some elite university hospitals staffing almost exclusively USMDs and some community hospitals staffing almost exclusively non-USMDs. So these trends overall beg the question, how do American trained MDs manage to remain so elite and powerful despite relying on non-USMDs, including some of the world's best and brightest, to fill almost half of all US medical residency positions? It's worth noting that hospitals are not formally required to prioritize US graduates during the match process at all. So to make sense of this puzzle, I draw on the social psychology literature this morning to show how shared beliefs at the micro level can result in broader macro trends of inequality at the professional level. So status beliefs refer to generally agreed upon beliefs that distinguish individuals along some characteristic, in our case, in this case, medical school of origin, resulting in differences in status or esteem. So the key question I'm tackling this morning is, what are the status beliefs surrounding USMDs and non-USMDs, and how do they help sustain powerful professional status distinctions in medicine? So to answer these questions, I draw on data from a 23-month ethnography of 2 internal medicine residency programs. The first was housed in a community medical center. I call it community hospital, and it staffed approximately 100%, actually 100% US non-USMDs in its 3-year internal medicine program. The second hospital was a more elite program housed in an academic medical center. I refer to it as University Hospital, and it staffed almost exclusively USMDs in its 3-year program. I conducted, over the course of 3 years, over 120 interviews, 9 focus groups, and more than 1,200 hours of participant observation at these 2 hospitals, which offered me a real-time glimpse at how status beliefs help distinguish USMDs from non-USMDs within the profession. So I found that residents from both hospitals truly understood that training backgrounds strongly determine professional status among trainees. It was a sunny October afternoon when I asked a group of USMD residents at University Hospital what was different about training at a place like University Hospital compared to a community hospital. And one of the residents replied smugly, quote, "Well, we're like the Navy SEALs and community hospitals like the National Guard." University residents therefore viewed themselves as elite leaders, while community residents, trainees, were viewed as followers, or in some cases, even as warm bodies brought in to fill gaps in healthcare. As one university hospital faculty member said quite bluntly with respect to non-USMDs, quote, the Caribbean people, and here they're referring to US citizens who trained in the Caribbean, they go on, they're picking up the scraps and the foreign medical grads are having a death match. There's a level of desperation. You've probably met some of these people who are like friggin' orthopedics professors in Tehran, ophthalmologists in Karachi. It's crazy. And they come over here and they go into the family med, internal medicine, or psychiatry programs, give everything up. So importantly, however, as you'll see, many non-USMDs also viewed themselves, much like this hospital faculty member, as gap fillers, doing the work that no one else wants to do. And they took on these lower status positions willingly and often with enthusiasm. So this presents a puzzle. What beliefs sustain a system where a group of professionals willingly fills gaps for another group of elites? In other words, why are those orthopedics professors from Tehran filling so-called National Guard roles in community internal medicine programs rather than competing with USMDs for elite positions in, say, orthopedics? Well, I found that respondents from both hospitals generally viewed USMDs as more meritorious. And here, by merit, I mean both as better and more deserving of elite positions in the profession. When I asked whether USMDs should be prioritized for residency positions, one USMD administrator from University Hospital replied, quote, quote, that US medical students should only get priority if it's clear that their preparation for residency is superior. Right now, in most cases, I think it is, end quote. In reality, however, mean licensing exam scores, this is USMLE Step 1, Step 2, you're probably familiar with these exams. They're some of the biggest predictors of residency placement. They're virtually identical when comparing between matched USMDs and matched international medical graduates. In fact, if you look specifically at non-US citizen international medical graduates and you separate out that group, they tend to outperform American citizens of all stripes on Step 1 of that licensing exam. Furthermore, elsewhere in the book, I show that decision makers at University Hospital routinely discarded virtually all non-USMD applications for residency, citing academic performance and professionalism concerns without actually reviewing their files to corroborate these concerns first. So USMDs are often unquestioningly believed to be better qualified, even when non-USMDs outperform them. More than being better qualified, however, USMDs overwhelmingly felt that they were more deserving of residency positions than non-USMDs. So in return for successfully playing the game, as they called it, of getting into an American medical school, USMDs expected to get first dibs on the residency positions of their choice. And this is what I call in the book the professional social contract with its trainees. And many USMDs were quite explicit about these expectations. In the words of one USMD intern, quote, we're all training with the idea that we've been told by our medical school that we're going to get jobs afterwards. And now what if all those jobs are going to other people who aren't from the US? If all these programs now are only taking people from other countries because they have more experience, where would that necessarily leave all of us? End quote. Now notice here that merit took a backseat to entitlement in this explanation, with this intern feeling owed a residency position even more than someone with more experience. And this widespread belief therefore helped reinforce a system whereby even the most skilled non-USMDs, the ophthalmologists from Karachi, for example, didn't provide real competition for USMDs who felt they were more deserving of top residency positions because of what they had sacrificed to get into the profession and what they'd been promised in return. So it makes sense that USMDs would espouse beliefs that help elevate their professional status as Navy SEALs, right? Paradoxically, however, I also found that many non-USMDs agreed with many of these first two beliefs, which suggests that non-USMDs have come to embrace some of the very principles that lead to their subordination within medicine. So the question then becomes, Why would non-USMDs consent to such a subordination in status? There were two reasons I found. The first was the belief in hard work, and it was cited by roughly half of the non-USMD residents I interviewed. Remarkably, many of them surmised that hard work and dedication were the key to unlocking success, and by that logic, believed that USMDs must have therefore worked harder or more consistently than they did to justify those inequalities in status. So take Harvey, for example. He was a first-generation college graduate who excelled in high school, but he struggled a bit in college, and he ended up going to a Caribbean medical school. When I asked Harvey about his prospects for residency upon graduation, he replied, quote, "As long as you work hard, as long as you finish in the top half of your class at a Caribbean medical school, you're going to get a residency. Whether or not you get a competitive one, that depends on how hard you work, because obviously the chance of getting dermatology or orthopedic surgery coming from the Caribbean doesn't look good. So, but if you really want it, nothing is impossible," end quote. So Harvey, like many non-USMDs, truly believed that with enough hard work and dedication, anything was possible. Sound familiar? Yes, it's the good old American dream, right? Except when we juxtapose Harvey's beliefs with the reality on the ground, we see just how misguided they were. When I asked Louise, a program administrator at University Hospital, remember, which staffed almost exclusively USMDs, about the chances of any Caribbean graduate matching to their program, she replied bluntly, "Probably as close to zero as you can get. I don't even know if we've ever interviewed someone from the Caribbean," end quote. Now, University Hospital didn't openly advertise this position, so the lack of transparency in the residency selection process only helped stoke beliefs in a meritocratic process where hard work could unlock all doors. Now, the ugly corollary to this belief in hard work is that if one doesn't reach their goals, it's because they didn't work hard enough. This led to a lot of self-blame. So in the same interview where he said that anything was possible, Harvey, who was unable to match into his preferred specialty of anesthesiology, admitted, quote, "I mean, it was my own fault. I screwed up in college. I should have studied a little bit more. I wish there was someone there kind of like giving advice. I would tell my younger self, do this instead," end quote. Now, his comments here are powerful. He's really emphasizing his role, or what we would call agency, right, in going to the Caribbean. But he may be unintentionally obscuring in the process the structural obstacles like a lack of guidance. Remember, he's a first-generation college graduate, which he only mentions in passing. And so in this way, Harvey internalizes the legitimacy of his lower status in the profession. Finally, the second major reason why non-USMDs accepted the status quo was the realization that they were among the lucky few who did make it. One resident from the Middle East, for example, explained that the US is, quote, "filling the gap with people like him who trained abroad." And when I asked him, how does it feel to be one of those doctors filling this gap? He replied, quote, "It doesn't bother me, because there are already thousands of people who want to be filling this gap and they're not able to get here. I mean, for us, being here by itself, I'm not complaining. It's an accomplishment," end quote. So this in turn was a willing participant because he knew how hard it is to get a spot. Now, interestingly, a comparable number of residents cited relief at getting positions as those who cited rather self-blame for their positions among the non-USMDs I interviewed, suggesting that international and osteopathic graduates use a variety of ways to make sense of their professional status. But importantly, I want to emphasize that both rationales serve to reproduce the system of power. So in sum, shared status beliefs help privilege USMDs over other graduates, deeming them as more meritorious, and thereby legitimating their occupation of powerful elite positions within medicine. At the same time, I also found that non-USMDs consented to occupying lower status positions either because they counted themselves as lucky to be part of the active labor force, or because they espoused the very ideology that finds USMDs to be more meritorious. Remember, better and more deserving. So status beliefs form part of these invisible social forces that I argue contribute to a larger process that I call in the book status separation. That is the process that helps USMDs float to the top of the status hierarchy, kind of like oil separating from water, and pushing non-USMDs towards the bottom, creating a professional buffer to shoulder that elite. Today, I've had the opportunity to talk to you only about one of these social forces, namely the status beliefs. But in the book, I find that broader class inequality, professional sponsorship, structural inequality among training programs, and then eventual differences in merit resulting from the above inequalities all contribute to status separation in medicine. So I'd be happy to talk further about any of these processes in the Q&A or answer any questions you might have. But for now, I'm going to thank you for your attention. And I look forward to a fruitful discussion shortly after.
Thank you, Tanya, for this wonderful talk. Yeah. Okay. Yeah. Okay. I'm here. Perfect. Okay. I see myself now. Okay. Yeah. Okay. So now we'll turn to Lauren. Yeah. Lauren is the second speaker. So Lauren, you have the microphone now.
Let me. All right. I shared the wrong one. Okay. How is that? Good? Okay. All right. Well, I will get started. And I just wanted to say that it's such a delight, and thank you all so much for inviting me. This has been such a treat to be able to be on such a great panel of scholars of power in health professions education, and I just really admire all of the work that comes out of the Wilson Center. So I'm just really happy to be a part. So today my talk is entitled "The Conscripted Curriculum and the Power of Medical Education in Reproducing Racial Inequalities." And it starts with a set of discursive problems and solutions. And this is just like a little a snapshot of some. And so there are a couple problems in particular, and this has motivated a lot of my research, which is the problem of paternalism and the biomedical gaze, which is the solution is that medical students need to learn to respect the humanity of their patients. And then there is also the problem of inequalities in health and healthcare, again, where there is this solution that's pitched that medical students need to understand the social context of patients. And so in line with kind of these sort of broader debates that are happening both within medical education and then beyond, social scientists and humanists alike that are kind of critiquing the medical profession. Again, these are very, I'm specifically describing them as discursive problems and solutions because these are problems that have been sort of framed and then solutions that are pitched at the level of curricular practices. And I know a lot of the scholars that are here have been really critical of kind of this narrow view of these solutions. But nonetheless, as a sociologist of kind of knowledge production and application within medicine, I'm really interested in how within this kind of narrow confine, how medical educators decide and make decisions around incorporating the humanities and social sciences into their curricular practices, why they make the decisions that they make, and then of course, what the impacts of these strategies are on student learning. And this is my broader project that I'm engaged in. And in the course of that research, I actually found a variety of different strategies of incorporation, which I am working on writing about in my book. But today I'm focusing on one, which is the conscripted curriculum. And I'm actually going to jump right into the data because we have such a great group of scholars here, so we can kind of discuss some of the implications of this and some of the theoretical takeaways in the Q&A. and discussion point. So the data that is behind this work is from this broader, largely qualitative analysis based on in-depth interviews with medical educators and students from 37 different medical schools. And I also engaged in non-participant observation at international and national here being the United States, medical education conferences. And then I gathered curricular materials and analyzed the different organizational features of MD granting institutions. So here I am, excluding DO schools in light of the previous talk. So what is the conscripted curriculum? I would like to kind of give a definition right off the bat. So what this practice is it's a concept I've come up with when medical students are conscripted to teach each other by sharing their lived experiences as members of particular social groups. And as I'm going to show in this talk, I'll first kind of round out this kind of basic definition with some of the data. Then I'm going to get into how it arises and then get into its implications. So in terms of a description of this, I'll begin with the students. So I'll start with Riva, and she was a white medical student in her 3rd year of medical school. And so she explained, students are asked to share about their own culture or racial background, and then sort of discuss how that influences their work or how that would inform their work. It's run by physicians, and it's not usually always people who have any particular training in like diversity training or anything like that. So I think sometimes the conversation sort of glides on the experience of the students. So while Riva's point about the faculty being inexperienced is certainly important too, and something I'm going to return to later, what I'd like to draw attention to here for sort of defining the conscripted curriculum is how students are explicitly asked to share about their social lives and experiences. And that it's these conversations that are the kind of material for learning about social inequalities, and they're very dependent on student sharing experiences. As another example, as Robbie, a 2nd-year white student, explained to me in response to my question about how he has learned about racial inequalities, he said, I think the thing that pushes students to think about it more is other students. And I don't think it necessarily should be the responsibility of the rest of the class to educate their classmates, but I think that that's what happens because of class structure. Robbie highlights how other students are educating their peers and that this is part of class structure, a point I will also expand upon later. So the conscripted curriculum in this case is thus predicated on educators' expectation that students will share their personal experiences with race, and that in sharing these experiences, other students will learn about the social nature of race. And as an abstract pedagogical strategy, the use of the conscripted curriculum, it is ostensibly harmless. However, due to the realities of medical school classrooms where faculty have this vacuum and do not teach about a social understanding of race, and students of color are underrepresented, students of color are often disproportionately placed in positions of instruction by virtue of their social background. So as Marian, a student of color in her 3rd year, says, I spent a lot of time in my 1st year trying to educate people, students and faculty alike. I'm constantly the only Black person in the small group because there's 5 of us in the whole school. As she highlights, she's often the only student in her small group due to the underrepresentation in the medical school writ large. And educators were, so this is kind of in hearing from the students, educators were more likely to conscript students of color in the classroom. And they often invoked the experiences that these students would bring, that students of color would bring the content. So for example, Dr. Kearns, who's a director of the practice of medicine or PALM sequence where race was taught, explained to me that the reason why instruction was effective was because they were a pretty diverse student body, so it's not like there wouldn't be a wealth of experience in the room. And in response to my question about when students learn about race, Dr. Lombard pointed out that some students, they're not native English speakers or from America, so they have their own cultural concepts that they bring to the patient and to the case. So I think that's where students get the content. And many of the white students and educators uncritically extolled the benefits of the diversity of the students for this curricular incorporation strategy. And as another example of how students of color were more likely to be conscripted into sharing their experiences, Dr. Gina Tazio, a medical educator who answered my question about whether students were instructed on race, explained, sure, I mean, we did one of those exercises where like you all stand up and then you all sit down after the certain qualifiers and you see who's left standing. So what this exercise prompts students to do is publicly identify with a particular social identity, right? Sit down if you've never experienced racial discrimination, and then uses that as a springboard for particular discussions around race, right? Whoever's left standing, please share. So in this type of session, students with visible social identities like race are conscripted into participating solely due to their membership in that social group. So now now that you have an idea of the conscripted curriculum, I'm going to get into a little bit more about how educators come to enact this strategy. And so this is kind of the three parts of this. So first is just the presence of the LCME standard without really sort of explicit instructions of how to go about it. So this kind of vague standard. Then I want to talk a little bit about how there is this lack of faculty expertise, and then talk about the practice of medicine's strong group or small group, strong group. Okay, so I'm not going to go over this standard for sake of time, as I'm already running like I won't run over, but I'm close to running over. So in the standard, what I just want to sort of emphasize is that there is a kind of, these are vague standards that don't really have instructions on what exactly to teach. And so it's in this void of instruction, combined with getting into the lack of faculty expertise, that things get kicked to the practice of medicine small group. So because these standards don't specify how to teach social inequalities, medical educators also have to decide what about these topics they'll cover and what educational materials they're going to provide. And most medical educators, and here these are those with an MD degree in my sample, so really clinical faculty, they reported that they didn't really have an in-depth understanding on the social underpinnings of race. And students also echoed this. So Jan, a fourth-year medical student of color, explained that they weren't taught anything about actual racism. And as Riva mentioned earlier, they weren't usually people who had any particular training. Moreover, as Jeremiah, a fourth-year white student, explained that faculty were not equipped to teach anthropology or sociology. Sam, a second-year white student, recounted this awkward memory of when her faculty member tried to facilitate a conversation about race in actually a small group. And Sam told me that the faculty member described a situation like, okay, you have a patient who needs to lose weight with diabetes or whatever, and you go over these different foods they can eat. And then Sam said how the educator continued. He goes, well, you can't just tell them to go out and cut carbs because they're eating like fajita bread and this is their normal diet. So you have to work with them. Sam was explaining to me that she felt that the delivery was awkward. She went on to recount another example from this educator's facilitation. I remember that is one example of the Hispanic population. We watched a video and a lady's crying because she can't get enchiladas. You feel awkward for watching. While it was unclear to me whether Sam or the faculty member described tortillas as fajita bread, this example from Sam's experience with this faculty member points to the broader issue with medical educators lacking expertise. And in fact, some educators were aware of this problem teaching race and tried to develop faculty around it. So for example, Dr. Bennett, who was a dean of diversity and equity at a top-ranked medical school, and also a former kind of practice of medicine course director, she described a 2-hour faculty bias training that she did for the faculty. And she gave them a worksheet with 7 social categories on it. The instructors were were kind of to examine their biases around these social categories and rate their discomfort with the topic. She recounted, and so when we debriefed about that worksheet, it was fascinating that everyone skipped over sexual orientation and race. People did not want to have conversations around their own discomfort or discomfort around issues of how they view people who are gay, and how they didn't want to talk about how they viewed people who were racially different from them. Dr. Bennett went on to say, they were really focused on issues of weight. So every person in the room wanted to constantly talk about their discomfort with obese people. And while we discussed her reasons for why that was problematic in and of itself, she went on to say how she prompted the faculty to try to get someone to discuss their level of discomfort around sexual orientation or race. She said that everyone was like, oh yeah, we're good. They just didn't want to touch it. And I'm a facilitator. I'm not forcing people. And when she pushed it further, asking if they found anything doing the worksheet exercise that they were surprised about, she still got no engagement. She concluded, I was hoping somebody would say something. Nope, nobody. They weren't telling. And I had like 75 faculty members there. So I'd like to highlight with this example just two things, and then I'm actually going to wrap up because of my time. And it's not only showing that the medical educators by and large weren't equipped to discuss race in small groups, but it actually shows that in this faculty development training, it is modeling how to conscript people, albeit not effectively. And so rather than receiving the instruction on sort of systematically collected data on the historical and contemporary manifestations of racism, they're prompted to discuss their own feelings and experiences with the subject. Okay, so I am going to just wrap up here, and because I am over time, and I am going to skip ahead and say that there are impacts, and really what those impacts are is that in the course of doing the conscripted curriculum and kind of creating it, without, because there is no intellectual infrastructure, this is faculty with expertise at these medical schools to teach upon the historical and sort of social significance of race and racism. What it does is it both simultaneously devalues this knowledge and then also unfairly burdens of student of color, which I would be happy to talk about in the Q&A. But thank you for your attention, and sorry for my time management.
Thank you, Lauren, for this very informative talk. Yeah, really interesting. Now we will turn it to Kelly. Yeah, Kelly, your turn. Thank you.
You know, it's been 2.5 years and I still forget to unmute myself. Let me just share my slides. Can everyone see this?
No.
No, okay.
No, we don't see your slide.
You tested this. Okay, there we go.
Okay.
I didn't hit the right button.
There you go.
Sorry. All right. Hi, everyone. I'm so delighted to be here today. I'm also thank you, Mathieu, and for organizing, and for, I'm looking forward to a really fabulous discussion after this, and to be among such brilliant scholars of medical education today. And, to echo Lauren, also, a huge fan of the work that comes out of the Wilson Center. So this is such an honor for me. So my talk today is going to be based on my book, which came out from NYU Press 2 years ago, called Feeling Medicine, which is about the pelvic exam. And so I'm going to present a slightly different talk. Despite being a sociologist, the talk I'm going to present today is a little bit more STS-y, cultural studies, in the sense that I'm going to give you some history and sort of we'll take a journey through history together, and then I'll overwhelm you with a little bit of theory. So the form of power and the enactment of power that I'm really interested in today is the use of emotion and what I'll call affect, which are bodily capacities to sense, to feel, and to relate. And so I want to focus today on how emotion becomes both a target and a strategy for upholding the professional dominance in the medical profession. And I focus specifically on techniques that are taught to medical students in formal coursework on professional and clinical skills. And these are techniques that arise from very specific historical conditions and processes. And they're aimed to create good physicians, and I'm using good in quotation marks, who embody the norms and the values of the profession and who cultivate, again in quotation marks, good patients. So the argument that I'm going to present today is an idea that modifying emotion makes doctors trustworthy, which makes patients more likely to be compliant. So I'm looking at how we're modifying the feelings and the values of medical students in order to produce physicians who are securing patient compliance. So that's the big picture thing that I'm doing in the talk. And so I focus in the book and on the talk today on the case of GTAs, who are gynecological teaching associates. So these are female-bodied people who teach the pelvic exam on their own bodies. So they're simultaneously serving as live models while explaining the techniques of communication skills and manual exam skills to medical students. So these are used based on the study that you're looking at anywhere between 72 and 90% of schools in the United States and in Canada. And they're growing in popularity in other parts of the world as well. And so I focus on the pelvic exam in particular, even though it's a very, very tiny piece of medical training, and most physicians after training probably won't perform a pelvic exam unless they're in family medicine or OB-GYN. But it's an interesting exam to look at because of the ever-presence of emotion. Both the people who are receiving pelvic exams and the people who are giving pelvic exams have a lot of emotions about this and need a space to sort of learn how to handle those. And so the historical shift that I want to trace today is the shift from what a sort of neo-Foucauldian analysis would call a disciplinary regime of medical education, which is a more physician-centered regime of medical education, to what we would call a regime of control or a patient-centered model. So let me give you two different examples of these regimes that I'm talking about. So on one hand, you have Charles, who's a medical faculty member, and he tells me when I was sort of asking about the history of GTA programs, right? He says a faculty member would go down to the public clinic, manually select a woman, say, you're going to come upstairs and teach the pelvic exam. Not are you or will you, you are. He would completely cover the patient with drapes, including the head. He would go into the exam room and the students were probing down this anonymous vagina and roll her out. Then he'd give her money. Contrast that to the regime of today. Heather, a program coordinator, tells me, I like the fact that GTAs are sitting up. They're able to see what the practitioner's doing and not laying back where they can't see anything. They feel by training young people early on and getting them in the habit of proper communication and touch and different techniques that help make the whole experience less scary, like you're going to look forward to your provider. So these quotes represent two different regimes of practice for teaching and learning the pelvic exam in medical school, one before and one after the advent of GTA programs. So in the first quote, Charles, who's a senior physician, is reflecting on how a previous generation of medical students at his university were taught the exam. A woman who is there possibly for gynecological care, possibly for something else, is being forced to have medical students examine her in exchange for her quote unquote free healthcare. In the second quotation, Heather, the coordinator of a GTA program, reflects on how medical students are taught today. So instead of an anonymous vagina coerced into the exam, you have well-paid volunteers who are using their bodily expertise to train medical students on more than just the most basic components of the exam. So these women sit up, they look their trainees face to face, they teach them about communication. Emotion is never mentioned in Charles's example, though affects of disrespect and dehumanization are cultivated in medical trainees. In Heather's example, the patient's emotion is centered, cultivating affects of attentiveness and empathy in trainees. The exam should be less scary, even to the point of being something that patients look forward to having. One might think, if one is familiar with the literature on professional dominance, that the paternalistic model is the only enactment of power. But as I suggest in my book, enactments of power in medical education have become more polyvalent, more multi-sided, and more subtle. Control is exercised through cultivation, not coercion. So by creating the right kinds of subjects to perform the pelvic exam, medical educators today want to cultivate the right kinds of subjects among patients. So let me give you the very brief methodological overview, and I can talk more about this in Q&A. But as I mentioned in the beginning of my talk, right, GTAs are highly trained lay people who teach the pelvic exam to medical students in again 72 to 80% of medical schools in the United States and Canada. So GTAs arose in part from the women's health movement in the 1960s and 1970s. And so, as I'll show in a couple of slides, the legacy of feminist health activism remains alive and well in the programs today. GTAs were taken up broadly and refashioned by medical educators in the 1980s and 1990s as part of a wholesale move to standardize both the teaching and the evaluation of professional skills. So it's best if you're, physicians are familiar with standardized or simulated patients, best to think about GTAs as a highly, highly specialized subset of these. And the history of the GTAs comes out of the history of the development of simulated patients. And a lot of the GTAs that I interviewed also work as standardized patients. And so part of the reason that I think GTAs are so important to study and so significant for medical education is that the same communication skills that GTAs are teaching are often evaluated in standardized tests of communication skills. So for example, in the United States medical licensing exam, on step 2, which is about communication skills, a medical student will interact with a standardized patient and will be evaluated on a lot of the same skills around empathy and trust and communication that GTAs are teaching. Or at least they did prior to the pandemic. It's still a little bit murky whether that part of the exam is going to come back. But students do have to pass OSCEs, for example, in order to graduate medical school. So this is a very, very small and niche program that for me evokes a lot of fascinating questions about emotion, professional identity, and expertise. So where do GTAs come from? GTAs come from a sort of three-pronged strategy or three-pronged historical situation, let's call it. That's a very technical term that involves the challenges to professional dominance in the 1960s and 1970s. So in the book, I show how the emergence of GTA programs from feminist projects to resist normative gendered practices in the pelvic exam. So prior to GTAs, medical students would learn the pelvic exam on clinic patients, such as Charles's example at the beginning of the book, or on plastic mannequins. They would also learn them from sex workers. And so these models had problems and reinforced the idea that the patient ought to be voiceless and passive in the pelvic exam. Or in the case of sex workers, that only those kind of women would be okay talking freely about this kind of examination. So this all changes with the women's health movement. In Chicago, a group of feminist medical students approached members of the Emma Goldman Health Clinic Collective, which is a feminist self-help clinic, to teach them the pelvic exam, mimicking some experiments that have been going on across the country at other feminist self-help clinics, most notably the Boston Women's Health Collective of Our Bodies, Ourselves fame. I also show how the rise of interest in standardized teaching and testing of communication skills in medical schools led to the emergence of GTA programs. So at the time, in the 1970s and 1980s, medical educators in the United States were very, very concerned about the sort of lack of standardization of how medical students were learning what we might call bedside manner or different types of professional and communication skills. And this was, in their view, leading to problems with the medical profession in the sense that patients, especially when we're thinking about reproductive health care, were seeking care outside. They were seeking care from nurses, nurse midwives. And so this lack of trust in the medical profession, in part because of this lack of standardization, was causing a lot of challenges for the medical profession's continued dominance. And so the idea of standardization, which is a theme in a lot of medical education history, becomes the solution to the problem. So in this move then from paternalism to patient-centeredness, we see three histories, right? Standardizing clinical skills training, which is about shoring up trust in the profession. The women's health movement, which is undercutting the bottom line of medicine by directing women away from traditional biomedical services. And the third history, which I talk about in the book, but I don't have a lot of time to discuss here today, is the changing demographics in medical education. In the 1980s in the United States, we go from about 21% of medical students are women to about 50% of medical students are women. So this rapid influx of women into the profession, right? They're looking around at how we're teaching the pelvic exam and thinking, this is not the thing. This is not the way to do this. So these three histories overlap and merge, and we see a new culture of professionalism emerge. This culture is sensitive to patient consumerism and the demands of managed care. It's a response, as I see it, to declining trust in the profession. It's a way to manage patients' feelings in order to secure trust and compliance. And so this occurs through these simulated patient encounters. So what you see here is a GTA teaching medical students some of the techniques. And so in the book, I demonstrate this redefinition of professionalism as clinical empathy by exploring the ways that medical students play with the skills GTAs teach them. So medical students learn things like proper language. So using what they call ICE words, which is inspect, check, or examine, as opposed to touch and feel. The use of gloves to maintain hygiene, but primarily to maintain an emotional barrier. Which all go into, and other such skills, which go into embodying these new skills of professionalism. And so simulation gives them, medical students, this new low-risk space to adopt these dispositions. So again, you see this cultivation of the right kinds of subjects, right? Good doctors through new technologies in medical education. And I don't have, I timed my talk, but I'm running a little bit short. So let me just very briefly situate this checklist. So this is the checklist that a GTA would typically fill out after an exam encounter to evaluate a medical student's performance. So checklists form a cornerstone of the seemingly objective work of evaluating trainees. They concretize the norms and values of good clinical practice. And so as you can see, emotion is very central to the practice of the pelvic exam. So just remember back to the beginning of my talk where I was comparing Charles to Heather, and you can really see this checklist concretizing the changes that Heather was championing. And so I show in the book how this is intended to produce a compliant patient. So they're demonstrating empathy. They're using appropriate eye contact and body language. They're demonstrating concern for the patient's comfort and modesty, and they're explaining to the patient what's being done. And in particular, this one about demonstrating appropriate eye contact and body language, right? In Charles's example, you have patients who are lying flat on their back with a drape sheet, and GTAs teach medical students, right, to just, this is just a very simple example of this, to put the table back upright so that the trainee or the future physician can maintain eye contact with them and then just make sure that everything's okay. And remind them that they're also an active participant in this examination. So let me do the theory piece now. So I do apologize, I'm presuming a little bit of familiarity with these sort of neo-Foucauldian legacies. So I use the case of GTAs to argue that managing emotion in medical education today involves systems of expertise that target, control, and reshape the affective capacities of the body. So the capacities of our bodies to sense, to feel, and to relate. And I call these systems technologies of affect. And I conceptualize them as being part of a broader sort of apparatus of what I'm calling affective governance in medical education. So this thinks about the new ways in which our very capacities to relate to one another, to experience social life, and to sort of engage in embodied interactions with other people are targeted by systems of knowledge and systems of expertise. And I draw this from the work of philosopher Michel Foucault and others who gives us the concept of biopolitics to analyze the dual relationship between the production of knowledge about a population and the management of individual bodies. And I update this with this sort of new literature on societies of control, which is this idea that the sort of institutional sites of power, such as the clinic, the school, right, these institutional sites of power are sort of losing primacy in contemporary social life. And instead, what you see is, instead of these sort of downward pressures for discipline, you see sort of continuous modulation of subjects. And so if you think about Charles's example, right, that's a really clear example of discipline and control in the pelvic exam. In Heather's example, through the modification of emotion, you're just seeing this sort of continuous modification of emotion instead. So expertise then serves to guide and continuously modify the choices that we make about our lives. And the sort of, instead of having these institutional spaces and experts taking on the burden of governing us and making us do the right kinds of things, we take those things up ourselves, right? We become self-managing and interested in turning ourselves into the right kinds of subjects. And so I engage with the literature on affect that thinks about how the body is the sort of site of these interventions and the site of these targets. So the modifications of how people feel assist in the production of certain kinds of subjects, right? How we are made to feel shape the kinds of people that we want to and are able to be. So for example, hope or trust in biomedicine can make patients into more willing consumers in the work of Nick Brown. So the target of control isn't making subjects who behave in socially appropriate ways, but are just sort of this never-ending modification. So in sum, right, I'm arguing that these new forms of standardization in the pelvic exam and in the teaching of professional and clinical skills are really about targeting emotion and the capacities to sense and to relate in order to produce physicians who take up these new norms and values of professionalism. And I argue that teaching and learning the pelvic exam through the use of GTAs demonstrates how affect or emotion has instrumental value for upholding the cultural, political, and economics interests of the medical profession. And I don't have a lot of time to talk about this, but also the forms of resistance that are possible. So thank you for your attention and your patience with me being just a touch over.
Thank you, Kelly, for this great talk. Thank you very much. Yeah. Now we will turn it to our fourth speaker, Paula Rowland. Paula, the microphone is yours now.
Wonderful. Thank you so much for this opportunity and this invitation. I am thrilled to be part of this panel. I've been reading this panel's work for quite some time, and it's a delight to be with you on this virtual stage. You all have such interesting topics and big topics, and I'm going to talk about boring things, mundane things, enactments of power and day-to-day work. So just give me a moment. I will set up my slides. All right, no one has their camera on, but please do tell me if you cannot see my slides, not you. So the topic that I'm speaking about is this notion of sorting things out, classifications, standards, policies, the boring things, the mundane things that shape our day-to-day work. And I'm going to start with an interview, and I'm going to read it because I'm not sure what size your screen is and whether you're able to see it. Surgeon. It doesn't bear thinking about, really. Researcher. What do you mean? Surgeon. Well, it could have been a lot worse. The table collapsed beneath me just as I was about to make the incision for the laparoscope. It just dropped to the floor. It could have been really serious. Imagine if it was a few minutes later. Pause. Looks at the incident report. I'm really quite appalled at what we have to work with. The patient could have been seriously hurt. Researcher. So the patient's okay? Surgeon. Thankfully, medical devices needs to undertake a thorough audit of the equipment and the instruments. It's not the first time this has happened. Researcher. So it's happened before? Surgeon. Not to me, but this kind of thing seems to happen a lot, and nobody seems to listen. So that experience was then translated into an incident report by one of the nurses who is part of the operating team that experienced this table falling midway through the surgery. Now the incident report reads, report number 1102, incident severity 3, type, near miss, type, equipment failure. Description, patient was on the operating table approximately 10 to 15 minutes into the procedure. When the operating table dropped to its lowest position, action taken. The operating table was checked by the staff, scrubbed at the table for steadiness, and the operative procedure was completed. The operating table was removed from the theater managers informed, incident report completed. That incident report moves through the organization. It's taken up by a risk manager. And now the risk manager has the task of translating that incident report into data that's going to be inputted into their patient safety management system. So now the report reads, report number 1102, type, other incident, classification, no adverse outcome. Description, during the operating procedure, the operating table dropped to its lowest position. Staff checked the table for steadiness and the procedure was completed. And so all of that data is coming from a study by Dr. Justin Waring. He's a sociologist in the UK. And his study was about these narratives of patient safety and how organizations build knowledge about safety and how that knowledge moves through the organization. And what he was tracing is how the experience of a safety event is translated, transformed as it's created into data, as it moves through classification systems within the organization to become managerial data upon which policies and actions are taken. And what its study shows is how these narratives, they become narrow. And of course, something is lost as we move from that interview with the surgeon, where you hear the haunting aspects of what if? So yes, it was a near miss, nothing happened, but what if it had? And I really like following on Kelly's talk, because there's an emotional aspect of the experience that gets stripped away as we move into the incident report. And the incident report gets stripped further as it moves into managerial data. So yes, these narratives become more narrow as they move through the organization and as they interact with risk management systems that are built upon particular ways of classifying safety events. But we also gain something. As these narratives become more narrow, as they're classified, they become countable. They become something that can be considered within the aggregate. The organization can start to see patterns and trends. And in that way, as much as there's a reduction of knowledge, there's an amplification of knowledge production in the kinds of things that we can see across the organization. And that's what I'm trying to draw attention to, this notion of classification systems. And I use the patient safety example in incident reports because they're likely familiar to anybody who's worked in an organization that's had to do something around creating an incident report. And so you'll hear me talking about classification systems, but also standards and standardization. And when I'm talking about classification systems, I'm referring to a particular terminological standard, a accepted norm about how something is defined. And those definitions are usually endorsed by important and institutional groups that are quite powerful. So the standards create uniformities. Using these agreed upon rules, you can create patterns and trends over time and across space. And these classification systems, they make things work in particular kinds of ways. They make things work across time and across space, and they're important and valuable for the work that they do. And so some of the works that they do that are a really common, powerful classification system that shapes healthcare is the International Classifications of Diseases. And so we know that this classification system allows us to influence how healthcare is financed, administered, the bureaucracy of it. But the classification system of diseases also shapes knowledge, what we can learn about, what we can study, what's considered a legitimate disease and what is not. Bowker and Stark talk about classification systems as ordering the messy world of the patient body into the ordered world of medical knowledge. And so it's an enactment of power to create these classification systems. And it's powerful groups who find the lists that are created to be both obvious and unproblematic. So you know you're in the margins of an organization or a profession if the classification systems that animate those institutions don't make sense to you. So one of the critiques of the patient safety movement is the way the classifications of patient safety incidents really prioritize and favor physical harm. And yet patients often want to talk about the inhumanity and the incivility and the objectification that accompanies their role as a patient within the organizations. And the way our systems are currently set up, the way events are classified, do not give room for those kinds of conversations. But I know that there's organizations like University Health Network that are attempting to shift those classification systems and make room for more fulsome ideas of how we think about patient safety. So there's power in creating the lists. There's enactments of power and the list being obvious, but there's also enactments in power to keep these lists alive. There's ongoing work that is required to make these classification systems work. So there's entire regimes of continuing education that are built around this idea of not only disseminating the classification systems, but enforcing them and correcting them when people get them wrong. And so it's Hodges Day. I have to invoke our patron Saint Foucault as well. And so I want to refer to classification systems as not being good or bad. There's certainly things about them that are good, that allow work to be done in a particular kind of way. And there's also problems with some of the way the classification systems work. And so what makes them potentially dangerous is the way that they can disappear into the background and how they might contribute to harm. So we can see examples of this kind of harm when some conditions are classified as diseases, and there's entire social movements that want to reclassify. So certainly we saw that when homosexuality was considered a disease category, and the kind of social movement to change that classification. And we will see entire social movements in trying to gain access to the classification system. And I suspect we're going to see something happening around long COVID to make that a part of the classification system to gain some legitimacy and the kind of attention that it needs to be able to be part of the medical apparatus. And we certainly see implications of classification systems and entire regimes of power that are hinged on classification systems around race. And I love this quote from Bowker and Starr, so I want to bring it forward in its entirety. But what they talk about, the notion of classification systems being dangerous, is when they become invisible. And when entire policy regimes are based on classification systems, and we've lost track of why some things are in some boxes and not other boxes. And they say black boxes are necessary, but they're not necessarily evil. The moral question arises when the categories of the powerful become taken for granted, when policy decisions are layered into inaccessible technological structures, when one group's visibility comes at the expense of another's suffering. And so classification systems are not new in healthcare. We've built entire systems around them. And so they create boxes about where information can go. And they do work, clinical work and bureaucratic work. But we're seeing more and more boxes, more and more classification systems. So it's not only clinical and bureaucratic classification systems, there's also research classifications, education, governance, policy. And so part of the work, the day-to-day work, is navigating these multiple classification systems, multiple systems of standards, and figuring out how they work together. And these systems have a tendency to want to pull apart. So healthcare providers have long navigated at these intersections of multiple classification systems. So in the patient safety example I gave from Dr. Justin Waring's paper, part of what he wrote about is the struggle that the nurse had to fill out that incident report, because the incident report, the drop-down menus that were available, did not fully resonate with the experience. And he also wrote about the surgeon's disillusionment with patient safety systems, because as the experience was translated into managerial data and it lost some of the emotional impact, the haunting feelings of what if something really bad could have happened. And as it got classified into a near miss, nothing happened, managers did not have the same kind of prerogative or push to be able to follow up that right away. And so the surgeon said, why make these reports when nothing happens anyway? And so you can see how things get both aggregated and downgraded as they move through the classification systems. And healthcare professionals have been navigating this for a long time. These are the quiet politics of day-to-day work. Because classification systems, they participate in what we can do, what we can say, what we can learn, what we can teach. Knowledge, identity, and power are all wrapped up within these classification systems. They influence and enforce the various ways we can work with one another and with the way we can work with patients. So to understand how knowledge and power and identity are playing out at work, I think we need to explore these boring things, these mundane things, these day-to-day things that shape our work in particular kinds of ways, but can become almost invisible because of their ubiquity, that we become so familiar with them, that we lose the capacity to question where these definitions came from and what kind of work that they do. So I hope I'm going to invite you into being excited about the boring things with me. And how does this relate to the notion of education science? Well, if we take a broad understanding of education science, the way that we have in our Wilson Center strategic plan, then we think about education science being about professional learning and knowledge, but also about the ways professional learning and knowledge is affected by the languages, the knowledges, the technologies, and the politics of healthcare and educational practices. And what I'm arguing here is that the relationships are changing, the politics are changing. Some of them are trajectories, existing trajectories that have always been there that maybe are escalating. But some of these trajectories are new, they mark disruptions in about the ways that we do our work. And I think it's in the scope of education science to ask, how is healthcare work changing? Is it changing by increment or by decree? Who is deciding? What new actors are coming into these spaces and shaping the trajectory of the kind of work that we will be doing? How are the professions responding? And what are the implications for health professions, education, and practice? And so we have a few studies that are within this domain, along with Nathan Capito, a PhD student here, Mathieu Albert, and Simon Kiddo at University of Ottawa. We have one study where we're looking at morbidity and mortality rounds as an indicator of a practice that's been in the profession of medicine for a long, long time. And we looked at the literature to see how it's changing. And so interventions into these rounds around their membership, their content, their process. And part of our analysis was looking at some of these changing regimes, particularly around patient safety and quality improvement, how classification systems were changing about what counted as something to be discussed, and also how these practices were being used in some ways as a mechanism to reinforce new classifications and to retool and reconsider how health professionals think about safety and where they categorize various kinds of events. And we have a new study that we're launching, Maria Malopoulos as the PI, along with Tina Martin-Makis and Nicole Woods. And this is around the concept of adaptive expertise. And of course, I will defer to Maria for any conversation about adaptive expertise. But I'm a good listener, I'm a learner, and I'm learning about the notion of adaptive expertise and this capacity to both complete efficiently routine work, but also to have the capability to be innovative as you're encountering novel or ambiguous situations. And so I know, especially in the Wilson Center, there is so much work around health professions education to prepare these kinds of future experts. But just as Kelly was saying, just as health professions education is trying to address novel ambiguous problems by creating people who have that kind of innovation capability, healthcare organizations have also been trying to solve novel and ambiguous problems. And their solutions keep tipping further and further into the notion of standards and standardization. So there's a real possibility that we could prepare future graduates around this capacity for adaptive expertise, and they could enter into organizations that are pushing further and further into standards and standardization. And I think we need to understand what some of those intersections might be and how to think about our role in these systems as healthcare educators. Both of those studies are pointing towards the same phenomenon. So I talked about classification systems, and to really make the point that they're not new. This is part of how we've organized healthcare for decades. But there is something new that is happening with the way classification systems are now being embedded into digital technologies, into health information systems. And so the question is, as we take these classification systems and put them into health information systems, does anything change? Is it the same, just in a different medium? And I like one of these quotes from Stephen Timmermans, who has a really robust, really interesting body of research around the sociology of standards. And he says, the work of making administrative standards work has largely been invisible. It's becoming more and more delegated to information systems themselves and increasingly to algorithms. And does that matter? And so just as these clinical systems are being embedded within health information systems, that's not the only thing that's happening within those health information systems. These health information systems are also serving managerial needs. So there's these new interests at play, and how these classification systems and the information systems that are in the digital technology, they allow people to access that information to audit, to monitor, to collect expenses. And so these categories become intertwined. And that is not necessarily new, but the speed and scale and the pace by which we can access this kind of information and make it work in new kinds of ways is accelerating. At the same time, we want these health information systems to serve research purposes. And we know that for the purposes of research, there's a whole other set of classification systems of what counts as good data for what purpose. And at the same time as these health information systems are serving clinical, managerial, and research purposes, there is a new actor in play who's creating these health information technologies. And increasingly, these industries have something at stake about how they develop these, market them, improve them, these big and expensive systems. So yes, it's true, healthcare providers continue to sit at the intersection of these classification systems, but the classification systems are becoming increasingly digitized. And these information technologies, I think they're accelerating the pace and the pressure of trying to make these standardized systems work. Because these health information systems, they merge together science, practice, bureaucracy, information systems. They are coordinating charts, reimbursement systems, professional vocabularies, patient identities, and healthcare professionals themselves. And these are big interconnected classification systems. And these health information systems are data hungry, and the data that they rely on must be useful. And to be useful to that many different players requires an amount of stability about the kinds of classification systems and standards and definitions that are being used to manage information. And yet, as these information systems become bigger and bigger, more and more robust, more and more interconnected, as there are more and more players that are trying to access this information for different purposes, I think it becomes much harder to hold on to this ideal of a pure universal representation of information and how it's going to be used throughout the organization. And Bowker and Starr have another great quote, is that we know from a long and gory history of trying to standardize information that a standard does not stay standard for long. One person's standard becomes somebody else's mess. And so there's work here to be done. And when these health information systems claim to change the way professionals work, the way that they think, I think it behooves us as educators and education scientists to take this seriously and to participate in these research agendas. Because I think there is a research agenda here that we could contribute to, that we could lead, that's inclusive of thinking about the kind of capabilities that graduates and practicing clinicians will need to participate in an increasingly digitized world. But I think there's other questions we can ask here about what these health information systems are creating, what new possibilities are created, but also what are the things that we need to remain attentive to, particularly as these information systems get bigger and bigger and bigger, and the classifications that they depend upon become less apparent, less visible. So I think we need to recognize that there's great opportunity here, but that these information systems, they are holding on to ethics and values, to previous decisions that have become encoded and maybe frozen into information systems. And to be able to keep inquiring into them, to keep them alive, to keep the places of fluidity, creativity, and along the ideals of what we're trying to create as we're trying to create health, I think that there is room here to contribute. So I'm going to leave this up just for a moment if you would like to take a screenshot. I'm really relying on Bowker and Starr's book here, but there's certainly some other really fascinating resources in this domain. I hope you find the mundane and the boring interesting with me. And if you want to email me for this reference list, I'm happy to send it to you.
Thank you, Paula. Thank you very much. I can assure you here that you are not boring, okay? Yeah. And it was not boring. Okay, a bit over time, but not boring. Okay, okay, that's good. Okay, Tim, you're up now.
Good morning, everyone. Today I'll be discussing enactments of power in health professions education, with an investigation into medical dominance and the production of pure space. We often think of space as something neutral. However, spatial theorist Henri Lefebvre challenged this notion and argued for a method that would reinsert social relations into its production. Foucault is another theorist that can help us think in the spatial. For him, space was crucial for the enactments of power, and he described space as being part of the history of powers whose influence stretched from the great strategies of geopolitics to the microspaces of the home, the classroom, and the hospital. And it is in these everyday spaces that I'll focus my discussion. How can analyzing enactments of power by problematizing space assist us in examining current issues in medical education? There's much discussion in the literature on how to mitigate bias and discrimination through widespread changes in medical culture, curricular development, and assessment and evaluation. However, there's a gap in understanding how structure elements such as racism functions within networks of institutional power to create advantages for some while marginalizing others. Arguably, by examining how power operates through the microspaces of healthcare, such as wards, clinics, or pharmacies, we can uncover how space has become an important mechanism that serves to emplace white professionals as rightful citizens, while at the same time keeping others in their place. Thus, professionals don't occupy space in the same way. My own experience as a white domestically trained pharmacist is much different than those trained internationally, who report their legitimacy is always questioned and the right to occupy space must always be proven, whereas my status grants me power to occupy space without question. The space of medical education is constructed as a neutral space in which other people's spaces and practices have culture, while medicine remains, in the words of Janelle Taylor, a culture of no culture. However, as feminist scholars famously argue, there's no view from nowhere. Thus, professional cultures have historically and tacitly reflected the dominant white patriarchal culture with its norms and values embedded in the ways we train professionals, but also how professional identities are constructed. Although professional identities suggest a certain homogeneity amongst all members of the group, feminist and anti-racist scholars Fellows and Razak redefine identity as being more aligned with difference rather than sameness. They argue that being a member of the dominant group means that one's identity goes unmarked and undefined by race, class, and gender. The norm is simply embodied, and the unmarking of dominant groups and the subsequent marking of subordinate groups means that in these authors' words, the processes of domination are obscured and thus intact. An example of this can be seen in the work of Tasha Wyatt and her colleagues who study professional identity in Black American physicians and residents. The participants noted how difficult it was to maintain a neutral professional facade when they were experiencing workplace trauma triggered by the racial violence that occurred in the summer of 2020. The trauma was intensified by a lack of psychological safety at work and by the fact that their white colleagues failed to offer any solidarity or acknowledgement of their grief at a time of heightened racial tension. Thinking spatially, the hospital was maintained as a neutral space by white physicians, as the power of their gaze allowed them to unsee race and view their Black view their Black colleagues as physicians first. This action, as noted by the authors, reinforced participants' feelings that white people do not believe in the existence of racial violence, nor in their complicity in maintaining the racial status quo. Thus, the power of not seeing maintains the racial and spatial order as white identities remained unmarked and unchecked. And as Fellows and Razak note, to have that norm unnamed also means to be innocent of the domination of others. This innocence is also present in our classrooms, in the spaces of our classrooms, as discussed by Lauren in her study of the conscripted curriculum. Lefebvre argues that we don't just exist in space, but there's a mutual relationship between space and bodies, in which space produces bodies and bodies in turn produce space. Thus, the social relations that converge in the classroom construct privilege and subordinate identities that belong or do not belong. And the classroom constructed as neutral reproduces identities of privilege through a pedagogical exercise designed to teach professionalism. In this space, marginalized students were marked as native informants who were recruited to teach their peers about their culture, while the identities of white instructors and students remained unmarked and innocent of their domination. How can space be analyzed as an enactment of power that reproduces the social order? Foucault suggests that power needs to be historicized and examined not from above, but at the space of the family, or in our case, at the space of the professional. And most importantly, he argues there needs to be an investigation of how power operates to secure status and privilege within larger political economic systems. In his historical accounts of madness and sexuality, he argues that the middle class did not care so much about madness or the sexuality of children per se, but rather their interest was in the micromechanics of power, those procedures and technologies that secured their place in the social order. Space, as he mentioned, has always been part of the history of powers, and historically, spaces such as the asylum acted as a mechanism to protect and separate the bourgeoisie from those marked as degenerate or abnormal, thus protecting the power and the privilege and the space of this new ruling class. Historically, the respectable Victorian middle-class home reproduced identities of privilege, and the European bourgeois male identity was constructed through spatial processes that segregated and contained those marked as subordinate. Fellows and Razak define these acts of domination as securing the center through the margins, a mechanism by which those marked as degenerate were spatially segregated into slums, institutions, and asylums, or in the case of servants, in the lower recesses of the household. Thus, as Canadian anti-racist and spatial theorist Shireen Razak argues, peripheral or marginal spaces symbolically and materially protected bourgeois bodies, the home, the class, and ultimately the nation from the contamination of the lower orders. How does power operate through professional space to reproduce identities of privilege and status? Guinea and Miller's historical count of professions in Canada provides clues to how today's professions are spatially and socially ordered. Physicians, clergymen, and barristers were the first professionals in 19th century Ontario, or Upper Canada as it was known. Unlike their British counterparts, they were white men of higher social standing. Pursuing respectability was essential for these new professionals to secure a place in the social order, and this was achieved through the pure space of the university. Pure spaces are essential for reproducing privilege and status. Thus, universities not only produce professionals, but professional gentlemen, whose education in the classics, according to Gideon Miller, bestowed upon them the qualities of character and culture which constituted one of the badges of their social authority. Thus, attributes of respectability and gentlemanhood were secured through the right education and social credentials. However, as Carol Schick argues, identities and spaces that depend on the legitimacy of domination are forever insecure. Thus, to keep out the other, state-sanctioned social closure mechanisms such as registration practices and admission requirements became important spatial technologies that operated to exclude through all systems of domination, including race, gender, and class. Today, privilege and respectability is gained through the acquisition of professional knowledge produced within the pure space of the university. Where knowledge produced outside the space is considered a threat and must be protected through social closure mechanisms such as credential non-recognition. The elite status of the university and its historically institutionalized power discursively normalized white Eurocentric knowledge-making approaches as rational. But in the process, alternative or diverse ways of knowing are often characterized as irrational and obsolete and pursued as a threat to established knowledge. Arguably, professional spaces can also be conceptualized as pure spaces, since a profession's status and ability to control its own work depends upon having an exclusive body of knowledge produced in universities. Thus, a profession's legitimacy and power to establish autonomy relies on the exclusivity of its knowledge base, and those trained outside its system bring diverse or alternative knowledge that threatens the privilege identities produced within. The purity of professional space is thus secured through spatial configurations that organize difference into hierarchies that are highly racialized and gendered. For example, from the critical literature in nursing, we know that spatially, white nurses are located closer to the center of professional privilege in higher status jobs that require more technical expertise and where there are more opportunities to advance. In contrast, INGs, or international nurses, are more likely to work in that periphery, such as in nursing homes, where work is more routine compared to hospital work and less valued than working in tertiary and ambulatory settings. When problematizing space and its role in reproducing social hierarchies, we may be guided by questions posed by Razak, who asks, what do such spaces enable, or what do these spatial configurations uphold? In her book, Doctor's Orders, Tanya investigates how hierarchies are reproduced in medicine. And when viewed spatially, we can ask how peripheral spaces such as the community hospital act as mechanisms that enable the reproduction of privilege and social status for those trained domestically. IMGs who pose a threat to the pure space of the university teaching hospital are spatially segregated and streamlined into less desirable positions, thus paving the way for domestic graduates to pursue upward mobility. Likewise, in the commentary in the AMA Journal of Ethics, authors ask how medical students who are the most unmarked by race, gender, and class are protected from the expectation of serving a diverse patient population, while the burden of service lies on those marked as different. The reproduction of professional status thus requires spatial arrangements in which underrepresented minority students, who are constructed as being naturally suited to the work in the periphery, serve an underrepresented patient population, while at the same time, privileged positions are secured for unmarked bodies who naturally fit into pure spaces of research and medical specialties. A spatial analysis allows researchers to problematize the neutrality of healthcare space and examine how power operates to preserve privilege and status for those unmarked by difference. Thus, as noted earlier, to be unmarked means to be innocent of the domination of others. So how can researchers problematize this innocence? And how can those who are most unmarked be made visible in systems that subordinate others? Whiteness studies researcher Liddell McWhorter problematizes the invisibility of whiteness and asks the question, where do white people come from? And in a Foucauldian critique, she advocates for a type of analysis that examines the reproduction of white subjectivities within networks of institutionalized power. However, I would argue that enactments of power need to be investigated not only at an institutional level, but at a level that Church and Young refer to as civilizational, where deeply held assumptions that construct the nature of our world and our experience of it operate for the dominant group at an unconscious level and become naturalized as societal norms rather than existing as historically evolved social constructions. Therefore, as Janelle Taylor suggests, our research gaze should focus not on the other, but rather we need to denaturalize the cultural dimensions of medicine itself. Finally, by asking the questions such as where do white professionals come from, we can appreciate historically the enactments of power that secured professional space for society's elites. Today's professional spaces and the identities produced within are constructed as neutral, and systems that dominate through difference are embodied as the norm rather than being foundational to how professions operate through exclusion. Thus, ways to address systemic racism and discrimination in healthcare, education, and practice requires professional educators and researchers to be reflexive of contradictions within our professionalizing systems that are on the one hand designed to protect professional status and ensure patient safety, but when unchecked, become mechanisms that reproduce the racial and spatial professional order. Thank you.
Thank you, Tim, for your talk. Thank you very much. I want to say, look, everyone, the speakers, I'm really impressed by the quality of your talk, the quality of the research that you're doing. You are the new generation of health profession education researchers in various domain or discipline. And really, I feel that you are bringing the scholarship in our domain in new, I don't know, new territory. I don't know to say that exactly in English, but really, like, it's impressive. Thank you very much.
First of all, like Mathieu, I'm just in awe of this panel and the wonderful talks we've just been a witness to. And also, I'm not sure about you guys, but right now my head is spinning. So I'm going to take these next few minutes trying to put us in a mode of reflection. I think it's very hard to take away everything from these talks because they're so dense with information and implications, particularly for us who work at the interface of both producing the educational science and also helping it find its way to work in health professional training. For me, an overarching theme in this series of talks is really the interplay between social and professional identities. And it was very clear that all the speakers' references to enactments of power in some way brought it back to issues of identity or processes of subjectification, which, as you know, I'm a Foucauldian admirer, so I'll draw from Foucault. This concept of subjectification makes us think to how we come to categorize individuals and attach them to some sort of identity signifier. And this kind of signification imposes a kind of truth both on bodies and also the meaning making that they are authorized to make public or have known. It makes them seen or unseen, recognized by others as successful or unsuccessful. It's a kind of truth making that we socially, all of us, invest in because it helps us sort of think ethically, or categorize things as ethical or deviant or normal as abnormal, insiders or outsiders. It's a way of functioning, but it has really a lot of implications. And as each scholar pointed out, some of these implications are undercutting well-intentioned efforts to reform. So Tanya started us off with a talk that exposed how dominant values about what constitutes quality in medical training have given over to asymmetrical control, as she talked about it, over to social prestige or status, to US trained MDs. And while she was using US as a case study. We see this kind of phenomenon happening in Canada, as Tim reminded us, but in other contexts as well. This idea that we hold the dearest positions for our own graduates, yet we rely on imported labor for quite a big a chunk and the bulk of health professional service, and that those. And the ways in which we sort of buy into these dominant values are very important for educators to consider, because much of it is in the process of celebrating the prestige of a school, celebrating excellence, presuming that excellence at one stage in one's learning career actually translates into competence overall, and that there's no way that things that you did in college that may have made you less productive in your learning or less capable of showing your potential can be mediated through any additional training. And it was very striking to hear the words of one of her participants, and I'm going to quote them back again to remind us that it had internalized this blame. I was stupid. If I had to do it over again, but no, I mean, it was my own fault. I screwed up in college. I should have studied a little bit more. And these comments are not really about how this particular non-USMD performed in medical school, but rather how they did in pre-med, the training they received subsequently, their performance, no matter how advanced, their current knowledge and skills is never going to avail them of the career opportunities afforded to USMDs, because this participant did not fulfill what Tanya referred to as a social contract. Everyone has come to believe that in exchange for years of so-called hard work, debt, and deferred gratification, US-trained MDs are more deserving of the residency of their choice than any other trainee coming from any other part of the world. And that's an important consideration, that this kind of dominance of a particular group is internalized by all other groups, which means that by allowing ourselves to be subsumed in this in this belief, we also perpetuate these unequal effects in the workforce. So Tanya's work is a cautionary tale of how shared beliefs about status at the micro level, I'm quoting again her words, can result in broader macro trends of inequality within a profession. And her research was, as I mentioned, conducted in the US, but really, truly, the mechanisms of socialization that she's tapping into really hold immediate relevance to Canadian medical education specifically, as we'll hear from other examples, but also for other parts in the world. These are general trends. Just moving on. So our next speaker, Lauren, overviewed how in an attempt to address racial disparities in the provision of healthcare, medical professionals, again in the US, has started delegating the instruction of the social underpinnings and consequences of race onto students, particularly students of color. And she introduced the concept of the conscripted curriculum to capture how students' social identities are then utilized by educators in the professionalization process. So really, again, this is a US case study, but we can recognize it as educators in Canada because we're drawing on the same pedagogies. And this idea that the lived experience of the learner is important in the way we organize, plan for, address quality issues, reform, apply the curriculum is common. So we have practices, not only a small group work where we ask students to relay their experiences to us. We have other kinds of practices like critical reflection that's done publicly. Sometimes it's done publicly amongst peers. Sometimes it's done in writing. And these things then capitalize on the lived experience of the learner in the hope that the learning experience will be better for that learner who is invested in this. But Lauren's cautionary tale exposes a dimension of discrimination that results from not being deliberate about when to use these pedagogies. So these pedagogies can be very effective, but they can also be very dangerous. And Lauren argues that if your social identity falls into a topic relegated to conscripted curriculum, you will likely be implicated in what will end up being very emotionally exhausting and unrewarded labor, particularly if you're a minority and you're always called upon to represent the identity group that you belong to. So, this is another reminder that when we assume that socialization can be standardized, empirically, we are showing that it really isn't. So things that we put in the curriculum that we think will benefit all students end up potentially benefiting only part of the student body. And that's an important lesson for educators. From Lauren's presentation, I also took away the message that we need to problematize the idea that professional identity is more salient than social identity. We've invested a lot of time in professions thinking about professional identity and what constitutes it, especially in terms of planning for the socialization of medical students and planning that their experiences within the classroom and outside the classroom are aligned. We also can take away from Lauren's presentation that faculty also have social and professional identities, and they can also interfere with the best laid curriculum plans. So we shouldn't forget that faculty are a kind of tool in the delivery of curriculum. We have a role to play. We have to execute a particular plan, yet we are humans and individuals, and we have our own ideas about what works best and what we bring to our educational practice. And most of all, we have agency in the way that the students do not. So often unintentionally, faculty who hold identities, and we all do, as a kind of expert, a knower, many conferred as excellent teachers, sometimes don't want to commit to the necessary retraining or untraining to achieve the mandated goals of addressing things like systemic racism and discrimination. So we have then decisions that are made based on what's more functional or what's easier rather than what should happen in order for us to really realize what we want to execute in terms of our reform agenda in education. The other reminder is that science is neither neutral in its creation nor in its application. And we have a lot to gain from the scientific breakthroughs of both basic and clinical science discovery. But Lauren's presentation reminds us that we need to carve out an agenda for sociocultural research that both exposes the enactments of power that perpetuate inequities in healthcare, but also guides us in our agendas for reform. We heard less about how we can be guided for reform, but I think that can be coming on in our discussion. Our next speaker, Kelly, also referred to a case study that exemplified the potential of theorizing and exploring enactments of power, not only as top-down effects. She problematized this idea that all power in medicine is paternalistic, showed us historically how in one context, paternalism has actually shifted, but then suggested that power hasn't gone away, or its effects of power have not gone away, and drew out some potential unintended effects by looking at how power now circulates in a more polyvalent, multi-sided, more subtle way through the application of ideas of patient-centeredness. So what's striking in her presentation is that the move to patient-centeredness was generated as a way to, first of all, it was something that emerged out of patient movements as well, provides more agency, supposedly, to patients to be able to bring their agenda to the forefront. But as Kelly has exposed, it also is another way for the profession to maintain its control over how it delivers its activity. Her talk showed us that the training of expertise serves to, quote, continuously modify and guide the choices we make about our lives. So to study the dynamic sociopolitical matrix that contributes to expertise development requires a researcher to investigate, quote, the complexity and diversity of the relations between authorities and subjects, and the ways in which such practices have not suppressed freedom, but on the contrary, sought to make up subjects capable of exercising a regulated freedom and caring for themselves. And I know this is very theoretically dense, but I think we need to pay attention to this because what it's drawing us to is to think about the ways in which we cultivate ideas of how to practice medicine. This ethical, moral consideration comes across in everything that we do in education, and it goes beyond socializing trainees to a code of conduct, and it goes beyond preparing trainees to be able to be proficient in a body of knowledge and its application. Theorizing identity and expertise development as interdependent opens up the possibility for new types of interventions for reform. And I think that's what these presentations in combination are drawing us to think about. There is an interdependency. So if we can think about that interdependency in our work, we might be able to think about ways in which our reform agendas can preserve agency, leave room for resistance, and maybe anticipate the profession's need for self-preservation in the process, but without tipping it to preserve the profession over the needs of the patient. Moving to the next speaker's talk. Sorry. Paula exposed the unintended effects of classification systems also as a form of power. She noted how and walked us through how classification systems are ubiquitous. And while we have scientifically and socially benefited from this kind of formalization of knowledge, she also reminded us that such systems can undermine our educational missions as they stifle creativity, can amplify dominant viewpoints, and can hold people captive in very unproductive relationships. So Paula's talk also overviewed how powerful groups find these lists and classifications to be natural, obvious, unproblematic, because most often they're the ones creating them. And she warned us that, quote, if you know you are in the margins of an organization or a profession, if you would know that you're in the margins of an organization or profession, if the classifications that animate those organizations don't really make sense to you. So that's a warning, right? So if we pay attention to these warnings, how people don't fit into classification systems, it gives us an opening to think about how we can invest in tweaking things that are right now useful in our system, but maybe leaving some behind. Paula tells us that these things are quiet politics. They're hard to apprehend unless we're deliberate about thinking about them. But she also linked them to power and identity and how it plays out. And particularly in this era where we're investing a lot of our energy in setting up information systems that make our lives easier. It's really hard to contest the technology that's brought in to make our work more efficient or offer services in a more consistent and standardized way, because it helps clarify accountabilities. But really what she's trying to expose here in her work is that there are unintended effects. And if we don't pay attention to these effects, we might miss out on the ways in which one person's standard is another person's confusion. I love the quotes, Paula, that you use. I'm going to end with one statement. Professional work is a delicate balance of autonomy and accountability, visibility and trust. In navigating this balance, Paula, I think it must be learned, and this too becomes an important component in the socialization of trainees into the profession. So thank you for that, because you gave us a lot to think about as educators. And moving to our last speaker, Tim uses spatial analysis to understand how elements such as racism and discrimination function within networks of institutional power to create advantages for some while marginalizing others. I liked how we bookended our panel today, because I think Tim's presentation works really nicely with Tanya's. His work, like that of other panelists, also centers the issue of identity and intimately relates it to how authorized roles are constructed through the way we institutionalize dominant ideologies and practices, particularly how ideologies about what counts as expertise, competence, professionalism get institutionalized. And he also problematizes the idea that education and socialization of learners is innocent. I think the entire panel has shown us in various dimensions how education is anything but innocent. Tim showed us how traveling across healthcare spaces, cognitively or physically, requires ongoing negotiation and identity work. And he makes it clear that healthcare is a space of white privilege, and through day-to-day educational practices, we either are aiming to enhance this white privilege, and we do it in a way that we do it in the name of quality and safety. And in this, and I'm going to quote again, this emplaces white professionals as rightful citizens to be in this space and to own the space and to have authority over the space, while at the same time keeps others in their place, which is really outside of the central happenings. So despite the appearance of diversity in professions, we don't really occupy space in the same way. And Tim reminded us that professional identity as a construct presumes that we can socialize health professionals to a shared ethical moral script. But the problem is, as he has argued, is that this idea has been written, this script has been written by a dominant group, and the experiences of social identity then become unmarked and undefined by race or gender or sexuality, because the norm is simply embodied by the dominant group, and they don't have to problematize their existence. Yet everyone else has to make do with that the dominant existence, and therefore has to constantly negotiate their way into healthcare spaces. There are so many lessons here for us. For one, we must appreciate that we have the power to create the space. Space produces identities that belong or don't belong. So our starting point can never be that the classroom or any learning environment is automatically constructed as safe and welcoming for all students. I think our starting point needs to be that we are all complicit in reproducing things when we're not deliberate. So I'm going to close in the same way that I started. The enactments of power described by all speakers in some way relate to the ways we've come to categorize individuals and the ways in which we impose a kind of truth on them, a kind of identity, making them recognized or unrecognized in our spaces, making them valued or unvalued, normal or abnormal, professional or unprofessional, thinking about this binary of insider and outsider. It's for this reason that education is never neutral. Every curricular decision we make about what to put on the syllabus or leave off, every decision we make about what to study or what to put aside, every pedagogical technique we have in operation today contributes in some way to these complex negotiations we heard about that both learners and faculty must navigate as they try to both decipher and then decide whether to assume or resist what is curated as professionalism, as expertise, as advocacy, and so on. Our presenters today made it very clear that we cannot leave things to chance. Most importantly, the door will not automatically open for everyone. In most cases, it must be pushed to open. And while we know that where we are now in medical education is not good enough, we're still working out what constitutes better. And I hope that part of our discussion actually is a kind of imagining what the future spaces of medicine can look like if we begin from the assumption that we have a lot of unlearning to do, that diversity is not a challenge to quality and excellence, and that social prestige is not a predictor of competence, that social identities are implicated in professional identity scripts. So I'll leave it there and open it up for discussion. Thank you.
Thank you, Tina, for these very thoughtful comments. I really appreciate this. Yeah, so we have time, absolutely, a good chunk of time for discussion, conversation, Q&A. Yeah, the way to proceed to ask a question is, yeah, so we will use the hand raise, the virtual hand raise. So to get there for people like me who are sometimes lost on the internet, so you click on the reaction icon, and then you have the yellow raised hand that you can click on. So please, yeah, question, comment, yeah, it's please. I don't see any hand raised so far. People need to think. Those all the talk were like strong and deep. Yeah, the talks with depth. Oh, I see. Okay, is it Paula? You have it? Yeah, yeah, Paula. Okay, yeah. So unmute yourself.
Oh, thank you. I really enjoyed hearing all of these talks and how they were put together. And I'm sure I want to engage with each of the content areas. But the question I was holding on to is actually for Kelly, and thinking about the world of patient engagement. And I really appreciated coming back into the history and thinking about the connection to social movements, feminist movements. And I wonder if your research has also explored these other domains of patient engagement that don't share that same history in social movements, but are taking up some of the techniques and technologies around that kind of engagement, but are coming from other spots, coming from consumerist type discourses, or coming from very medicalized discourses of their own? And has your research gone into that space?
Sure, thank you for that question and for your talk. I found it really fascinating, and I liked how the connections and thinking about standardization and the sort of concretization. And Tina, also thank you so much for such a wonderful commentary on that. So I trace a little bit the history of patient consumerism as one of the motivating factors behind this. I definitely think that the declining trust in the medical profession in the 1960s, 1970s, and 1980s is in part also about sort of managed care and patient consumerism. And this, and in the last chapter of my book, I really engage with what Michelle Murphy, for example, talks about with self-responsibilization of patients as the sort of like product of consumerism, right? Like the patient, the way that patients exercise, at least in the United States, for-profit healthcare system, right? The way you exercise agency and power is as a consumer, as a shopping around for doctors. And so one of the things that I think is really interesting that I mentioned in the book, but I don't trace, it was just sort of beyond the book, was sort of the history of how patient satisfaction as a metric, right? And it's one of the like public reportable metrics for hospital and healthcare systems that receive Medicare and Medicaid is patient satisfaction. And so I definitely see this sort of like increased interest in standardizing teaching and learning about empathy as being tied to sort of the rise of patient satisfaction scores in healthcare. But it's sort of a little bit beyond the book, but I talk about it in other work that I've done in other publications that I'm working on.
We have a question from JC in the chat. Mathieu, would you like me to read it out?
Yeah, please, yes.
Regarding Tanya's talk in particular, but perhaps one for all the speakers that they might be able to address, how do we distinguish beliefs from post hoc justifications of the status quo, or are they the same thing?
Yeah, thank you so much for that question, JC. It's really hard to disentangle this, right? You know, I think I certainly saw a number of folks trying to kind of make sense of their current position by kind of post hoc looking back and sort of making certain justifications. But I want to stress sort of how prevalent these beliefs are within sort of the sphere of medical education. One of the things that I certainly observed was that these beliefs exist and in fact sort of shape career trajectories before folks even end up going to medical school. And so, for example, one of the questions I asked DOs or doctors of osteopathic medicine, you know, was why did you choose the DO path? And a number of them felt that this was even before medical school had started. They felt that it was more important to study in the United States than to go outside of the country the way Caribbean graduates, for example, might do so. Conversely, Caribbean graduates felt it was more important to have the MD behind their name than to study within the US in certain cases. So his beliefs are really widespread. They're also used as justifications for decision-making surrounding the match process and who sort of gets ranked and who gets interviewed and which applications get discarded even before being reviewed. So I think you're tapping into a kind of dialectical or a process whereby, you know, beliefs that are widespread and uncontested within medical education are used to sort of shape decision-making within the profession. And then they're also used as sort of post hoc justifications after the fact. And so there's sort of a really dynamic, complex process, I think, that's going on there. Thank you for that question.
I see in the chat box a comment from okay, it's gone. Okay, where's that? Okay, from Brian. Where is okay? It's all gone, and I wanted to read it.
I'll read it for you. I'll read it.
Yeah. Okay. Tina's good. Yeah. Okay. Yeah.
Wonderful. Wonderful
Okay, go ahead.
presentations. I think the silence may be to some degree the need to absorb and reflect on this work. My own reflections today and going forward will be about how this rich and essential theoretical work can link to institutional practices, perhaps via the crucial role of clinician scientists.
Yeah, look, is anyone, it's not, does anyone do have a comment on this? So it's the question about the connection between the academic work that we're doing and the, I don't know, the practice, the everyday practice in the medical school, in the hospital, in the education. Can someone comment on this? Yeah, Lauren, go ahead. You're mute, okay.
Yeah, so I have a few thoughts on this. And it actually, I think, goes nicely with Jeffrey's question too. And especially Tanya's answer around like the process and when things start. Because I actually think not only can we think of making this sort of knowledge applicable to clinician scientists, but I actually think so much of this, some of this belief formation starts with like the STEM instructors at the sort of bachelor's degree level. And that is something, so I'm thinking of like, so that's another kind of group that I would really like to be a part of these conversations and thinking of changing practices, because I think as a sociology instructor of pre-med students, I am learning a lot about what STEM instructors are conveying to pre-med students about what is or isn't important, and I think that's like an important group of people to pay attention to as well, and in terms of kind of reproducing a lot of these dominant values. As far as clinician scientists go, I will say that I think even so, the work that I presented on, the data for that was collected a few years ago, and I think that there are places where, I mean, I think even places like the Wilson Center, thinking of all of you critically engaged social scientists and humanists that are there, and being able to kind of have these more robust conversations. But I think faculty development and this, Tina, you mentioned this idea of kind of retraining. I think that is, I guess I hold hope there. I know when I conducted my research, I walked away with this idea where I was like, if clinician scientists could actually understand and like feel a facility and comfortability in talking about systemic racism, that would be like a very great place to start. And this, I mean, but then again, I just want to sort of say that this, in terms of larger institutional practices, this actually, I was thinking about this a lot with Tim's talk and space, and thinking about specifically like, then thinking about like how an academic medical center is housed within not even just like the spaces where learning happens for med students or professionals are working in, but then the space around it and being embedded in a community and like hospital community relations and all of that. And so I think that now I'm rambling and I lost the thread, but I guess, this is what I wanted to say, that I think while faculty development of clinician scientists is a great place to start, it's definitely not the end point there. Okay.
Thank you, Lauren. I see that Rabia has her hand raised. Rabia, please unmute yourself and ask your question.
Before I unmute, I'd love to hear what Paula and Tim wanted to say to the last question, or anybody else who had their hands up. I would love to hear that, and then I'm happy to ask my question. Is that okay?
Yeah.
I just want to say briefly, when I read Lauren's work originally, and And just hearing, you know, some of the other presentations, you get kind of a sick feeling in your stomach. It's like, how could somebody, you know, be conscripted to teach others about them and have that focus when, you know, as she said, there's 5 Black students in the whole cohort, the kind of pressure. But I also thought, you know, by making and problematizing educational spaces as not being innocent, you know, Lauren, like if you turn the interview back to the educators and kind of problematize, like if we knew that this isn't an innocent space, that if we knew that there's power relations, how could we reconstruct our exercises? How can we reconstruct things? And I think also for Tasha Wyatt's work, the same physicians, where did they learn to make these spaces neutral? Where did this idea come from? From their training. This is, I think, a knee-jerk reaction. You know, there's stuff going outside this hospital that is uncomfortable. You know, let's keep the space neutral so we can be neutral and pretend, you know, it doesn't exist. So I think these are important mechanisms that are learned within our education. And I think certainly the work that I've done with Tina, we did a lit review that examined, you know, it's not just credential non-recognition, but this is a power, a way to enact power. Yes, we do need it, but at what point does it become a mechanism of exclusion and preserving social status, or even things like surveillance? I mean, we do have to watch out what our colleagues are doing, but when does that one mistake of an international graduate become a lifetime mistake? You know, when is it used? And I think this is unconscious, I guess, but never innocent. Yeah.
If I could, I wanted to respond to Brian's comment by first of all saying thank you, Brian, for being here, for listening, and also for making this day possible. Not just this day, but making these kinds of conversations possible with the kind of legacy and space that you've created for the Wilson Center and that you continue to create in your VP role and your many, many roles. And in relationship to my talk in particular today, thinking about where we could connect these theories and institutions and change and what's happening, I really wanted to explore and push into these ideas about workarounds and what kind of partnerships are possible between when you have the kind of theoretical apparatus and the distance and different things at stake, when you can look at how these things are evolving and how they could be otherwise because you're not embedded in the same way. And what kind of partnerships then are possible with the people who actually need to do the work. And there's something really, really rich, I think, to explore about the way people who are doing the work try to navigate it, how they navigate their moral dilemmas, how we think about healthcare is constantly rife with moral dilemmas, and how people work around the systems that are meant to control and construct their work, but how they work around it to actually get their job done in a way that is both moral and ethically appropriate. So thank you to Melanie Hammond-Mobilio, one of our PhD students, who brought the book Are Workarounds Ethical into one of our reading groups. But I think that there's some really rich opportunities for partnership for these kinds of conversations that explore with practitioners how they're navigating their worlds and how we can keep bringing these ideas together and build both knowledge, insight, and possibility in some of those inquiries.
If I could just jump in real quick and answer this question as well. I think it's a great question. I think I want to follow up on what's been said. But in terms of the link between theory and practice, something that I'm often thinking about is, I think that med-soc and med-anthro often deservedly get a reputation for just constantly being critical of physicians and critical of providers. You know, they're the holders of the clinical gaze. And there's so much, I mean, there are very valid criticisms here, right? Critique is a very important thing, but I think what's really excellent about today and all of the presentations in particular, Tim and Tanya and Lauren and Paul, thinking about sort of the system that providers are embedded in and physician educators are embedded in. It's not innocent, to use Tim's language, right? It's producing certain kinds of subjects that are also socially located. And so the thing that I think that is important to think about are both, as Paula just said a moment ago, right? The workarounds, right? The metrics, once they're established, take on a life of their own. And so I think being really, really conscientious that we are not just coasting on the standards and the metrics and reproducing the systems that developed them is really important. And then also in my other work, I've considered what I call a counter-clinical space, right? Which are these sort of like meso-level organizational spaces, which are very prolific. There are a ton of these types of spaces in educational spaces that are sort of at the edges of the organization, and so a little bit more amenable to change. So as much as I'm critical of, for example, of the pelvic, how we teach the pelvic exam, I also don't want to go back to what Charles was talking about, right? I don't want to be flat on my back with no idea what was going on. And so I think educational spaces, because they're sort of at the margin of the profession in a lot of ways, are a little bit looser and a little bit more amenable to social change. And so harnessing that capacity that Brian Masumi talks about as sort of like a experimental step as opposed to a utopian horizon is really important to think about.
Rabia, you now get to ask your question.
Sorry. And if we are hearing, the hawks are feeding their babies, so I apologize for the background noise.
No, it's not noise. It's beautiful to hear the birds.
Okay, so long and short of it is, I find it very, like, I love coming back into this community because I feel like there's a like-mindedness in terms of the research that we all tend to produce. And I find that very safe, but what, not necessarily knowledge translation, but in the ability to talk across disciplines or across different forms of professionals, I guess. I sometimes find that that's the part where, like, I struggle with trying to understand how is it that we can have such a clear vision within certain communities and groups of thinking about some of the ways that our work is practical, and then the way in which it gets hit up against when you're actually translating that into some meaningful practice. And so I guess the question I have is, in all of the work that each of you have done, where do you find those challenges and where do you find opportunities to help, I don't know, illuminate or grow somebody else's unlearning process?
Tanya?
Yeah, thank you so much for that really great question. I mean, I think if it were easy to fix, we would have fixed it by now, right? And so I think what you're getting at is, like, yeah, what are the kind of obstacles to translating the kind of work that we've described today into clinical settings? Remember that the theme of today's talks was power. And that's one of the biggest obstacles, that those in power oftentimes are, receive benefits for being in those positions and are therefore not necessarily inclined to change the status quo as a result of that, right? And so, I think that's one of the, I think Kelly rightfully pointed out that medical sociologists tend to be kind of very critical. It's also an occupational hazard of ours to be a little bit, I think, pessimistic in the sense that, power, the way power is distributed, people fight really hard to keep it that way, those that are in power. And so, I think in my work in particular, with respect to changing how the medical profession values folks that are trained in different disciplines, would require, I think, USMDs and those that are in decision-making positions of power to relinquish some of those benefits associated with being trained in the US as an MD. One of the things I talk about in my book that is a potential sort of way forward is potentially blinding the school of origin of a student when they apply for residency. Now, there are real obstacles to that, one of which is, right, letters of recommendation will very easily give away an institution. It's not quite like an orchestra audition where you can have, sort of the curtain and have somebody perform behind it. But, I think one of the challenges, like I said, really has to do with power arrangements and being able to sort of make effective change that would require redistributing that power.
Thank you, Tanya. Tina, you want to say something?
I think I'm not going to spend too much time because Tanya said most of it, but I was going to say that by virtue of focusing the gaze on power, we bring out a lot of the intentional or unintentional effects of power, specifically as our interest is to look at who's left behind. But I think the positive in this is that we are in a forum within medical education at the moment, and we're applying theories that are extremely, it could be perceived as extremely critical. And for many years, we're not part of the conversation because the only thing heard was the critique. And yet we have an opportunity, and we have seen change by drawing, even if we drew on, 1/10 of what was said today, we can make very positive changes to our system without overhauling everything. Critique of power doesn't mean we throw the baby out with the bathwater, right? So it's being vigilant and being able to act with a new kind of evidence base. And the other thing I wanted to note is I didn't highlight in my discussion as much as I could have because there was so much to overview from what was being said. But Paula touched on this. I think some of the most creative work that's happening right now is in medical education specifically, are projects that are transcending the siloed disciplinary approaches to fixing these very complex problems. So drawing in, cognitive science with sociology and seeing where that takes us, thinking about assessment and power, effects of power in a way that hadn't been done perhaps 10 years ago. I think we're going to see some creative stuff come out in the years ahead because of this kind of authorized thinking that we have right now.
Yeah, just a few words here. Totally agree with you, Tina. I think today panel, at least for me, what is telling me is that just to build on what you just said, Tina, that knowledge sources from various disciplines is excellent. This is what we need. And at some point and in some way, it needs to come together. Not that I am a strong promoter of interdisciplinarity and all that. It's all fun. It's all good. The point is that diverse source of knowledge at one point needs to come together in order to generate a better understanding of a social reality. And I think, look, I think we need strong academic knowledge. We need academic to have the freedom to think and do their work in a very highly academic way. But at the same time, at one point, we need to try to make, this is a cliche, but I will use it. We need to, as academic, we need to try to make the world a better place. It's not really like, I don't talk this way usually, those words, but you understand what I mean. In order to have some impact, social impact, for the better. But people know me. I'm still strong defender of basic science, academic science, and I mean by this, I'm a defender of the freedom of academic to do their work. Yeah, absolutely. Any comment on what I just said? Do you want to say something, Kelly? I see your hand is right.
Yeah, okay. I was thinking a little bit more about Rabio's question and the sort of like change, and maybe I'm going to take this to macro level, but something that I've been thinking about a lot lately and reflecting on is, since, and I'm in the US, so I'm very like US focused when I'm going to make this comment, but I'm thinking about, for example, the teaching of structural racism and concerns about addressing structural racism in academic medicine and the attention that it's received in the last 2 years has also come with it a lot of backlash. There was a former dean at Penn, right, who was just tweeting about, well, maybe it's just because students of color are less skilled that they do worse on about, like these kinds of ideas. So I think that having a clear sense of power and these clear theories of power help us understand these sort of waves of progress and backlash so that we aren't as academics and as educators who are concerned about producing more equitable effects in education, right? We're not caught flat-footed or surprised by these forms of backlash, is what I'm trying to say, right? Because right, people in power want to hold on to that power, as Tanya was saying, right? We shouldn't be surprised that we then see the theoretical tools that we're producing being used to undermine the points that we're trying to make.
Absolutely. I see there's no more question, so we will end this year Hodges Symposium. Yeah, at this point. Again, I want to thank all the speakers. Your work is important. It's well done. It's high quality, and I believe also that you are a very good talker. I know this is not English, but you present your work really well. Yeah. So look, so that brings us to the end. Okay. And bye-bye. And that was great. Okay. Bye-bye, everybody. Bye-bye.